tube into the mother's system, and then the needle is removed out of her back. The needle does not stay in her back. The tubing does, but the needle is removed instead. There we go. We've looked at that enough. We'll get rid of that. So that gives you a quick, brief look at epidurals. Now the tubing stays in. Medication can be continuously infused into that. We can have an epidural in for a brief period of time, just for a caesarean section. It can be administered at any time, even after a baby is born, and you might think, well, that's ridiculous. Why would you administer an epidural? If we're having difficulty delivering the placenta, then the epidural can be administered for manual removal of the placenta. Any questions about the epidural? So the side effects on the baby are considerable with epidurals, unless it's a last minute epidural. So by last minute I mean the woman has been in labour for some time. Now it's been decided that we definitely need to have a caesarean section. She's been drug free, and just at the last minute before having a caesarean section the epidural is administered. Under those circumstances I wouldn't be overly concerned about the baby. It's so last minute that minimal will go through to the baby. The baby that I would be more concerned about is that we've had the epidural in place for 5 hours or 10 hours. Some of those babies will be fine, other babies will be affected by the medication. So other side effects of epidurals, which you'd also find listed in the Cochrane database, if you go into Cochrane, C-O-C-H-R-A-N-E, find that on the internet, and then just simply do a search on side effects of epidurals, and then that will explain a number of other things, amongst them that an epidural will increase the risk of a woman needing a forceps delivery or a vacuum delivery or a caesarean section. So it's quite a powerful association. Once a woman's had an epidural, she's certainly increased her chances of ending up with a forceps delivery. Some people say to me, do they still use forceps these days? And yes, they do. I do have a set of forceps. Again, look away if you don't want to see a full set of forceps, or fast forward this. The forceps are stainless steel. Some people have a nickname for them, that they're like salad tongs. They are very effective in delivering a baby by emergency. So if we need to get a baby out extremely quickly, certainly the forceps will achieve that, especially if the mother's fully dilated. So the forceps are made of stainless steel for strength. There's 2 blades, and one would be carefully and gently inserted by an obstetrician. They can only be used at this stage by an obstetrician. So one blade would be inserted gently, carefully in the vagina up through the open cervix and placed into position around the baby's head. The other one to follow, in through the vagina, up through the open cervix, and again around the baby's head. So that's where the baby's head would be there. The forceps then, and the name forceps, force, does give away what's going on here, and a lot of force is used to pull the baby out of the mum's vagina using these blades. So the obstetrician would very carefully pull with a tremendous amount of force to pull the baby through the birth canal. Where are they applied on the baby? They're applied under the jaws and over the temple to bring the baby out through the birth canal that way. So that's when they're correctly applied. In Australia many years ago we had 3 types of forceps. I'm only going to call them large, medium and small, and nobody's allowed to use the large ones at all anymore because they were implicated with damage to babies. So these days forceps deliveries are a lot safer. You can be rest assured of that. The large forceps are hanging up in the obstetric museums these days. Now another alternative to forceps is called the vacuum extractor, or the ventouse. Again, you can search this, it is in the book, but it's also on the internet, and you can just type in vacuum extractor. This is using suction, and the vacuum is applied, the suction cup is applied to the top of the back of the baby's head to suck the scalp into the cup to pull the baby out of the birth canal via pressure on its scalp. I have one here. Look away if you don't want to see this. And this is the version of the vacuum. So this part here, the cup, is applied to the top of the back of the baby's head. The obstetrician would have the woman in a laying down position, legs in stirrups, and the obstetrician would communicate extremely well with the woman, saying, I need to use a vacuum to help your baby be born. Clearly you are tired, or we have some other reason why we need to use the vacuum. We want to hurry up and get this baby out. We're concerned about, for example, the baby's heart rate. I really need you to push at the same time as me pulling. So let's work as a team together. And then the obstetrician would insert this up against the baby's head and then suction applied onto the baby's head, and then the obstetrician pulling at the same time as the mum pushing during that contraction. The obstetrician would say, I'm just carefully going to place my hand on the outside of your belly and I will let you know when you're getting a contraction, and that's when I need you to push and to work with me. So they would work together as a team, and the baby would move down very considerably. Maybe the need for cutting an episiotomy, but maybe not. Certainly if the woman has used the Epino, I would recommend that the woman communicate that very clearly with the obstetrician. I have used the Epino. I did get it up to 7 or 8 or 9 centimetres. Maybe I'm stretchy enough that I don't need to be cut. It would be very unusual with the forceps for a woman not to need to be cut. But with the vacuum, I've had a few women where they haven't needed to be cut. So they've ended up intact, no stitches or minimal stitches. Okay, so once the head is out completely, the obstetrician breaks the suction, no need to use that anymore, hands it off to the midwife. The obstetrician would then rotate the baby is born, midwife clamp, cut cord, and assess the baby, dry the baby off gently, and then if the paediatrician gives the baby all clear, baby can come on to mum, skin to skin contact with mum. The next thing the obstetrician will do is ask the midwife to give the syntocinon injection to the mum. The obstetrician would fully explain the syntocinon injection and gain informed consent first before the midwife administers the syntocinon injection into the woman's thigh. So that injection will cause an artificially strong contraction of her uterus, getting it to expel the placenta. So it's just a one-off dose of extra syntocinon. The placenta will come out. The obstetrician will hand the placenta in the kidney dish to the midwife and say, please examine that and check that it's complete. The midwife will pass the obstetrician some gauze cloths. The obstetrician would check the vaginal area to see, do we need to stitch here? And then would do stitching. Now the stitching involves dissolving stitches that will dry out and drop out within about 7 to 10 days. Okay, so keeping the area clean, rinsing the area well, changing pads frequently, maximising hygiene, minimising the risk of infection are important things to do with if we end up with stitches. Do you have any questions at all? Now the other thing that we need to cover, of course, is caesarean sections. Yeah. So with caesarean sections, most people underestimate what's involved in a caesarean section, and our rate of caesarean section in Australia currently, our state average in New South Wales is 30%, around about 30%. So that means 1 in 3 women are having a caesarean section. The World Health Organization recommends that we have about half that rate. So we've got double what the World Health Organization recommendations are. And all of the Western countries have been looking at this for some time, and they recognise that our rate has come to what we refer to as a tipping point. There's a certain amount that's fine, and then once we've overdone that, now it's not fine anymore. It's no longer a benefit to our community. So some hospitals have a much higher rate than 30%, and what the academics have seen is that the high caesarean section rate has increased the rate of postnatal depression. So regardless of whether it's an elective caesarean or an emergency caesarean, what is recognised not just in Australia but certainly all the other Western countries is that mothers who have had a caesarean section are 10 times more likely to end up with postnatal depression. Now, some people say, look, that doesn't matter, we'll just give the mother some antidepressant medication. And for some women that will work well, and for other women that might not. With women who have mild postnatal depression, they might not be interacting terrifically well with their baby. They might not interpret motherhood as a favourable experience. And when they're not going out very much, depressed people tend to stay home a lot more. They're more isolated. That's not beneficial for the baby. The baby's not socialised. The baby does not develop resilience, certainly not social resilience, but not physical and emotional resilience personally within itself too. So the educators in our school system, preschool, kindy, infant school, primary school and high school, have certainly noticed a very dramatic drop over the last couple of decades with the level of resilience with our children. So the academics, the researchers have noticed that the quality of our community has decreased as a direct result of caesarean sections increasing, postnatal depression increasing, children's resilience decreasing. This is not what I call a dualism. This is evidence-based. Again, you'll find this in the Cochrane database. You will, if you just Google resilience in children, reasons for a lack of, then certainly you'll find it there too. New Zealand changed their law as a result of this research. They've altered it that any woman in New Zealand who wants to have an unnecessary caesarean, that means there's no good medical reason, she actually has to pay for it. So the government says nobody's allowed to have an unnecessary caesarean. The legislation says if you want that, if you insist on that, then you must pay for it yourself. So that law just got changed in the last decade over to you must pay for it yourself. Over in the UK, exactly the same. So they found that mothers, just simply through fear, anxiety, chose to have a caesarean section, and even they have postnatal depression, even though they chose to have the caesarean. So if they've already got anxiety, it needs to be treated during the pregnancy. Not the mother written off as, okay, she's anxious, let's just Caesar her. If she has anxiety, then that needs to be treated during the pregnancy with counselling. So the Royal College of Obstetricians in Australia have that as a recommendation. Instead of saying to her, yep, that's fine, let's just have a caesarean, they're saying, no, we must counsel this woman and help her overcome her fears and her anxieties of a normal birth. Encourage her to have a normal birth. If it does become necessary to have a caesarean section, then we need to have the necessary support in place for her afterwards as well to minimise the risk of postnatal depression. So it's very, very important. Now in Australia we don't have a change of law. What they've done instead is attempted to educate obstetricians, medical professionals and midwives to promote normal birth and educate about normal active birth and water immersion in Australia to promote normal birth, to keep birth normal, rather than opting for what appears to be a quick, easy opt-out, and that's epidural caesarean section. So on the surface of it, many people in our community see that as a quick, easy answer, but the truth is it may be more disadvantageous afterwards. So what I'd recommend is looking at caesareans as a nice little insurance policy in the background. If we need one, isn't it great to know that it's available? Otherwise, if we can minimise the use of a caesarean section, the mother is more likely going to be healthier and recover better from the birth compared when she's had a normal birth compared to a caesarean, and the baby we expect will be in better condition after a normal vaginal birth compared to a caesarean section. So is there anything that you'd like to ask about caesareans? No? What I'd recommend for partners is understanding that it's a very anxiety-producing experience for women, and to help minimise postnatal depression after the experience, I want to just talk to partners about what to do if we are in a situation of needing an operation. So the mother would be transferred with partner into the operating theatre, partner standing by her side and being her advocate. The mother's laid out. There'll be two obstetricians, a midwife and an anaesthetist. The dad will be sitting next to the mum, and she'll have blood pressure monitoring and a drip, and the partner would usually be located on the chair about there. Now, partner needs to hold her hand, focus completely on the mum. Don't say anything negative about the operation. Don't say, oh my God, I'm glad it's you and not me. Don't say, even though in an anxiety-producing situation many people will often crack jokes, and I can understand that, but it's just a moment of extreme sensitivity for this woman in her life as she's undergoing an operation and entering motherhood that way. So we need to be very positive and very respectful and very sensitive. And when that baby is born, and an obstetrician can actually get a baby out in 6 minutes, so it can be surprisingly fast, even though maybe we've been in labour for 12 hours, who knows. But sometimes people expect that in operating theatre this is going to take a long time, and of course it doesn't. So the baby is out. When the baby is out, we might hear that mucousy sound and suction, and then oxygen, and then there may be other noises or smells that we smell, and partner needs to remain 100% positive as much as possible. The anaesthetist will keep an eye on things. What a partner can do is pull their mobile phone out, set it up for camera, get rid of the password, and hand that to the anaesthetist and get the anaesthetist to take photos of mum and baby, dad and baby, or partner and baby, and mum, partner and baby. It's the very first of family photos, so that we've got extremely positive memories right from the start, and that this is a very special experience. So the baby will go to the midwife. The midwife will check the baby over, and also the paediatrician will check the baby over, and then especially if the parents are saying, how's our baby? Is our baby okay? Can we have our baby please? And then the baby comes to the mother. What I'd recommend to partners is undo her operating theatre gown, undo the back of her neck, pull that down to reveal her skin, lay the baby there, just unwrap the baby a little bit. The baby will be in a warm receiving blanket, a candy stripe pink and blue. Unwrap the baby a bit, put skin to skin as much as possible, hold the baby securely on mum's chest, and then talk very positively to the mum, saying things such as, wow, you're a mum? Hey, look at our baby, and I'm so proud of you, and I love you, and anything else very positive and loving and respectful that the partner can think of. She will remember this forever, and so will you. And so what's going on now is the delivery of the placenta through the abdominal wall, the stitching up, which will take about 20 minutes. That's the longest part of the operation, and what we need to be doing is ignore that and bonding as a family. There'll be transfer out of the operating theatre into recovery. Some hospitals do separate mothers and babies at that point. Most hospitals don't. The more forward-thinking, up-to-date hospitals recognise that that's an unpleasant experience for a woman to have her baby taken away from her. And so the evidence, the hospitals where they're practising more evidence-based, will be keeping the baby with the mum and letting them breastfeed in the recovery after the operating theatre. Now, the Department of Health of New South Wales has a policy of no separation of mother and baby 24 hours a day, 7 days a week, unless there's a very genuine medical reason to separate mother and baby. So it's very important for people to be informed on that, and for the partner to be a strong advocate for the mother and the baby to keep them together. Okay, so for the safety of the baby, the safety of the mother, mentally and physically, it's better to keep the two together. What are the disadvantages of caesarean sections? There is a bigger risk of infection in the wound. So I do need to let you know that if there's redness, bleeding, swelling, smelliness, anything to indicate an infection in the wound over the next few weeks, we need to move quickly to a GP or get medical help. If the woman feels as if her uterus is extremely sore and she's got flu-like symptoms, there's a sign of infection, and we need to act on that as rapidly as possible. If the discharge is extremely smelly, another sign of infection, we need to act on that very quickly. So that's the main points that I wanted to get across to you about caesarean sections. Some women find that breastfeeding after a caesarean section is extremely challenging. What I recommend is a big U-shaped pillow or other cushion over the wound while she's breastfeeding. Otherwise, that's very painful and unpleasant. We need to cushion the incision to make it easier for the mum. Some women like to breastfeed with the football hold. Okay, so that means bringing the baby around this side instead of over the top of the incision. And it's the same way that we would feed twins as well, the football hole. Yep. So after a caesarean section, what I recommend is that mothers have plenty of support, that somebody else is doing their washing, ironing, cooking, cleaning, grocery shopping, and light household duties, that some other sober adult is with her during the day if partner's gone off to work. Yeah. So somebody who's over the age of 18, a responsible adult by her side to assist her for the first 3 to 6 weeks after the birth. Most women in Australia are left at home alone, post-operative. Partner's gone back to work after just 1 or 2 weeks, and she now has to look after herself and the baby. I would regard that as severe neglect of a post-operative patient to be home alone, fending for herself and looking after a baby on her own. So I would appeal to all mums to network and find a way of getting the help that they need. It's the woman's responsibility to access the help that she actually needs. So whenever family and friends are saying, let us know if you need some help, don't automatically say, no, we're fine. We need to automatically say, yes, when? When can you come and help me? Please come and help me with my housework. Please come and help me with food and help me with cleaning and the washing. Usually it's the kitchen and the laundry are the 2 areas that we need the most help with. Not come and take my baby off me. Okay, so that's not really supporting that woman in her motherhood experience. But if people turn up, her friends, her family turn up to clean up the kitchen, and they bring food and they bring lunch, and they peg out all her washing or bring it all in and fold it and sort it for her, that's genuine help and support along those practical lines. So they could hold the baby while she goes and has a sleep. That would be terrific. Or wrap the baby up, pop it in the pram and go for a little walk while the mum has a break or a shower, looks after herself physically that way. They would be very appropriate ways of supporting. Any questions at all? I think we've covered most things. We've skimmed over the surface very rapidly, but I hope what I've managed to achieve is giving you a good handle or a few insights into, very quickly, medical interventions and drugs, with a few very important, helpful, practical, supportive tips as well. Thanks for listening. Okay, we'll go on to part 3 soon.